It's the Morning Majlis.
It's the Morning Majlis, and now we're going to be doing a little bit of a medical Majlis because we're very kindly joined in the studios by Dr. Ghalib Hussaini, who is the AUS Professor in Chemical and Biological Engineering. A very good morning to you.
Good morning to you as well. Thanks for having me.
Well, in a nutshell, we're looking forward to this discussion because what we do understand is this is going to be a new cancer therapy, a treatment with minimizing the side effects but maximizing the killing of the cancer cells. Can you talk to us about this process and how does it work?
Yeah, absolutely. So we're all familiar with the side effects of chemotherapy. Whenever I go to a conversation or give a lecture, the first thing they say, oh, it's the hair fall, right? And while that's devastating, it's not actually very serious to the life of the patient. There are many side effects that people undergoing chemotherapy go through, including problems with the GI tract, so they usually feel nauseous, and sometimes they can develop ulcers. There are problems with the immune system. Usually people undergoing chemotherapy are advised not to interact with the public. And also, even more pressing is that these chemicals are so strong, Rania, that they actually can affect the heart muscle. So last year, 30 people were declared in remission in the United States. Remission means that you're cured or they can't see traces of the cancer, but they died because of congestive heart failure because these chemicals are so strong, they killed the heart muscle. So there's definitely an incessant need for us to rethink the way chemotherapy is being delivered. And the way we do this is we take the chemotherapy, the active ingredient, and we put it inside a nano capsule. We call it nanocarrier, but I like to talk about a capsule because whenever you talk about medicine, it's always about a capsule, right? So it's a nano capsule. A nano is teeny tiny. So if you think about a ruler is about, you can measure probably millimeters. If you go 1,000 times less, that's about micrometers, and that's like a microbe, and you cannot see it with your own eyes. And if you go 1,000 times less, that's a nanometer, which is teeny tiny. So we're talking about a very, very small nano capsule. You cannot see with your own eyes. A lot of preps for us to actually see under a microscope, special microscopes. And then we take this active ingredient, the chemotherapy, we encapsulate it inside this capsule, and we put it through the IV. So it goes to the IV, the heart pumps it everywhere. But because it is still encapsulated, it's not going to interact with healthy cells in the body. And so once it gets to the tumor site, we need a mechanism by which we can activate it. And the way we activate it is using ultrasound. So again, it's kind of like a magic bullet. You activate it, Louis, when you want to. And hence you will avoid interactions with the hair follicles, interactions with the GI tract, with your tummy, interactions with your immune system, and with your heart, particularly with your heart. And this way you can improve the lives of cancer patients throughout the world. And, for me, I like to think that we're trying to make chemotherapy more humane, so to speak.
So I'd love to ask, it sounds like you're targeting the tumor not just one way, but two ways, biologically and with ultrasound as well. Can you explain that as potentially being, if you believe so, the future of cancer treatment? It sounds very innovative.
Yeah, so right. So I talked about these nanocapsules, and the patent actually, as you said, the patent itself, we're trying to target cancer 3 different ways. Okay. And if I get too technical, please stop. Okay, so the first way, if you look at the cancer, part of why the cancer is so dangerous, it grows so fast. It grows haphazardly. And when you grow haphazardly, you don't have enough time to have nice vessels. So the vessels themselves, those veins are defective and they have holes inside them. So if you make the nanocarrier under 200 nanometers in size, then it will passively, it's going through the bloodstream, but there's a hole. It's going to stick itself in the hole and passively release the chemotherapeutics. So that's one, that's called passive diffusion or passive targeting, and that's called the enhanced permeability and retention effect. Sorry, I have to tell you what. In case there are doctors, I have to satisfy the doctors too. So that's by size. Second one is biologically, as you said. So what I want you to imagine, on the surface of a cancer, there are locks, just like locks right here. And we take the nanocarrier, Rania, and we add the key to those locks to the nanocarrier. So each cell can be opened by certain keys. So for example, for breast cancer in our case, what would you think would be the keys that you can open breast cancers? We're talking specifically female cancer. So what are the hormones that women have that men don't have, or they have a lot less of. So one way is estrogen, one is progesterone, and one is Herceptin or HER2, okay? And these are the three main locks on the surface of the cancer cell. So what the patent that we got is we take the nanocarrier, we conjugate to it, chemically we attach this Herceptin that will go and open that lock on the surface of the breast cancer cell, okay? It doesn't, biologically speaking, we say it binds. So you have a moiety, which is the key, binds to the receptor, which is the lock.
Yeah.
And hence you biologically target that cancer. Am I getting too technical?
No, I like it. I like it.
Okay.
And the ultrasound, where does that play a part?
Yeah. So again, now you have a higher concentration, Louis, of these nanocarriers at the tumor site because you targeted them by size, passively, and biologically by the key unlock mechanism, Rania. So what you do now, you need a mechanism to activate them. You need to release their contents. So what you do is then you apply ultrasound right on the target site, and then ultrasound in a way shakes these nanocarriers and releases their contents right to the tumor site. Now, why do we like ultrasound? I think it's a perfect modality. It's been a huge part of my life for the last 25 years. Ultrasound is benign. You know, when I had 3 kids, we went to make sure that the kids are okay. We actually used ultrasound. We use it with neonatals. We use it with babies, which means it's very benign. Ultrasound, the technology has been around since the 60s of last century. It's very well understood. And ultrasound has the ability to specifically focus on a certain part, on a very small part where the tumor is. And of course, it's ubiquitous. It's everywhere. Every single clinic has ultrasound. It's not that expensive. And so it's easy for you to envision this where you go, you take the IV, the nanocarriers are pumped everywhere, and then you go to the clinic and then activate them for about half an hour and go home.
That just makes us want to also set the record straight regarding the safety concerns.
Yeah.
All right. So, how do you ensure that these nano capsules, as you call them, not the carriers, don't harm the healthy cells while they're on the way, on their mission to target cancer cells?
Excellent question, Ron. Yeah. So one thing is, remember, we're trying to open specific cells. So the way we target them, first of all, healthy cells don't have holes inside them. They're perfect. So we don't have holes. So passively, you're not going to be able to target them by size. Second of all, if you're looking at the key unlock mechanism, these, when you're talking about, for example, our patent, it is with HER2 receptors, okay? Human epidermal receptor 2. And what you do on the surface of the cancer, these guys are overexpressed 2,000 times more than on a regular cell. So if you compare a cancer cell versus a regular cell, that's going to get 2,000 times more into the cancer cell than a regular cell. So you might get a little bit into regular cells, but it's not going to have the effect that it would have on other sides of the body. So by size and by the biological targeting ensures that you're going to where it's supposed to go.
Okay. Now, another innocent question in line with that would be, why has this particular type of treatment not been discovered before or pushed forward, and what can the side effects be? Because obviously we pointed out that when it comes to chemotherapy, our first reaction is hair fall. What causes that, and can this one also follow suit?
Yeah, so what we're doing here now, the science of nanotechnology, where you have nanocarriers, started about 30 years ago. And basically, the idea of a nanocapsule has been around longer, but whenever they inject these nanocarriers, they go to the liver and they get detoxified and they never make it through the bloodstream.
Right.
So about 30 years ago, and it wasn't our group or anything, it was before even I started being a researcher, they discovered that if they add this molecule, right, so have a nanocarrier, if you add a spring to it, it's called PEG, polyethylene glycol, then, so again, you have a nanocarrier and you kind of add a spring to it. So the white blood cells kind of approach it, and in order for the liver to identify it as a foreign object, the white blood cells come in and they tag it. Okay, just kind of imagine. So if they're not tagged, the liver doesn't know that it's poisonous and it keeps circulating in the body. So the way scientists did this, they added the spring, which is polyethylene glycol, and the white blood cell approaches it and it comes in and it kind of squishes the spring.
Right.
But this is entropically. Entropy doesn't favor it, so it repels it. So what does that mean? 30 years ago, they found a way by which you can have a very high circulation time because the liver, which detoxifies things, gets rid of all of the toxins, the bacteria, the dust, everything that you do. The liver is very important, right? And will not be able to identify it as a foreign object, and hence it can circulate in the body for a longer period of time. So that was done about 30 years ago. The first patent of these nanocapsules, or the idea of nanocapsules, came out in 1995. However, they're not targeted. So what's new about what we're doing is we're not only targeting them biologically, but also with ultrasound. So we're using size, biologically key unlock mechanism, and ultrasound, and that's what's unique about this. I'm just going to be a little technical now, and I'm going to tell you. So people in our area in drug delivery were so excited about 4 years ago. There's a company called Thermodox, and it went to clinical 3. So I'll tell you what that means. What they did not use ultrasound, and their nanoparticles were not targeted. They're just regular nanoparticles that do not have the key on them. And what happened is that they went into clinical 3. So whenever you test these nanocarriers, you have to go through 3 different phases of clinical trials. Clinical means humans. The first trial, so I'm going to go preclinical. We synthesize them chemically, we characterize them chemically, and then we test them in vitro. In vitro means test tubes. And then once that's successful, you do it in animals. We are working on an animal model right now at the University of Sharjah, where we have mice. We inoculate them with a tumor. We inject the nanocarriers, and we apply ultrasound. That's called preclinical. Once it passes that, it goes through clinical. Clinical is 3 phases. Clinical 1 is between 10 and 100 patients. Clinical 2 is between 100 and 1,000, and clinical 3 can go to up to thousands. For example, the COVID clinical trials had 43,000 people. So, and whenever they talk about a clinical 3, it has to be people, male, female, all kinds of ages, all kinds of ethnicities from different countries, so that applies to all humans. So Thermodox, so I'm going to backtrack a little bit. So Thermodox is an amazing company that we're so excited about because I'm in something called trigger drug delivery. So we use ultrasound as a trigger. Made it to clinical 3, but the improvement, they used microwaves and the nanocarriers were not targeted. Okay? So they made it to clinical 3, but clinical 3, the improvement was only 5% over what's in the market. Now, in order for the Food and Drug Administration to approve it, you need to be 25% better than the market. And so our technology, I think, is superior, and I think it has potential to make it all the way clinical 3 because we are using biologically targeted particles, nanoparticles, which they did not use, and we're also using ultrasound, which I believe is a more powerful modality to release the contents. Because with ultrasound, you can use heat, and you can all use mechanical waves, which are sound waves, which is ultrasound, actually are mechanical. So if I bring a transducer now, if I bring ultrasound here, you put your finger, you see something pushing on. It's actually mechanical, okay? But microwaves are heat. So ultrasound, you can use the hyperthermia aspect. You can also use the mechanical aspect of the thing. And I think that's why it has potential to make it to clinical trials. And that's why I'm very excited. That's been my baby.
Very passionate about it as well.
Yeah, oh, absolutely.
You know, in line with what you just said, what kind of results or responses so far have been observed in studies or clinical trials, moreover, from what you just said, involving these targeted narrowcapsules?
Yeah, so we did, as I mentioned, we synthesized the nanocarriers, and then we characterized them, then we did in vitro. I mean, everybody knows the word in vitro because in vitro fertilization, it means it's in test tubes. So this is easy for everybody to identify with. So we did in vitro, and now we're doing it in an animal model, as I said. Now, the one thing that we proved that these nanocarriers accumulate at the tumor site. The targeted ones accumulate better than the non-targeted ones. And this is good. They accumulate 3 times better. What we're doing now is optimizing the ultrasound. So the ultrasound, so you can have a higher accumulation, but now the second part of the delivery is using the ultrasound. So what we do is now we're trying to see what would be the best frequency of ultrasound. Frequency is how many waves you have per second, hertz. How strong it is, that's called the power density. How strong is the ultrasound? And then we also pulse ultrasound usually. We don't turn ultrasound continuously, we turn it on, off, on, off. Rania, you know why that's the case? Because ultrasound is actually energy, and if we keep it if we keep it on the tumor too long, it might actually damage the skin. You might actually burn the skin. So what we're doing now is we're taking the animal model using these mice, and we're optimizing the ultrasound parameters. I'll just tell you something else, maybe that's interesting. We take a mouse that is immunocompromised. It doesn't have the immune system. Basically, they remove the thymus from it. Thymus is athymic. And so it's nude mice because the immune system, part of the immune system is to grow the fur, to grow actually the hair on the one. They don't have hair because they don't have an immune system. And then why do we use that? Because we want to have an easy way to grow the tumor inside these in these mice. So we grow cancer cells. We have cancer cells that we purchase from cancer banks in Europe or in the United States. We grow them in high concentrations, and then we take the hind legs in the back here, and we inject these tumors, human tumors. It's xenografts, so that's not the same species. And then we inject them in their hind legs on both sides. And we wait about 2 weeks. Then once it's palpable, once you can touch it, then you grew a tumor. Then we go through the tail vein of the mice. The biggest vein in the mice is the tail vein. We inject our nanocarriers, and then we apply ultrasound.
Okay.
Now, one of these tumors, remember I said both sides. One of them will have the ultrasound, one would not. So we can compare. Does ultrasound make a difference or it does not? And right now, we're getting good results, but we have to repeat it to make sure it's repeatable, and we replicate it. And once that's done, we initiated a conversation with the government. Then we can go to clinical trials. Now, we cannot do it at AUS. I don't think any university in the UAE can do it. We have to go through the government. This is big because it's patients.
Yeah.
And so I'm hoping that within 3-4 months we'll be done with optimizing the ultrasound in the mice, and then we can do further. We can see what the government wants further.
It sounds like the potential is pretty incredible, but I'd love to take it from a financial perspective. How is the potential when you compare the financial side of this practice or cancer treatment when you compare it to the regular cancer treatments on offer today?
Yeah, I mean, the nanocarriers are obviously going to be more expensive. The formulations are going to be more expensive, but I think governments around the world will pay for their subjects. So, yeah, I mean, the preparation technique takes a while. It takes us hours to get it done, and when you're trying to do it on a larger scale, it's even going to be more so. The nanocarriers that are being synthesized now are not very expensive, but obviously cost more than just the free drug, so to speak. But I think that the government will be willing, because it's going to help patients so much, to invest into paying for that. So. And
you said that the ultrasound is near enough every hospital, so that surely is an affordable side of it.
Absolutely, absolutely. Yeah.
Now, in terms of timeline, obviously now we've gone through the initial phase. Now we're doing the testing with the mice. We've got the clinical trials to look forward to. What are your projections in terms of how long it will take till it becomes a regular source of cancer treatment from now where we are?
Well, okay, so let me tell you something. It depends what the government thinks. COVID got approved within a year.
Yeah,
the vaccine. Yeah, and the UAE actually had a clinical 1, 2, and 3 vaccine. So I'm hoping that the results will be encouraging, that we can speed things up. And so I'm hoping within maybe 2-3 years we'll see this in clinics. If it might take longer, maybe 5 or
all
so.
All depends on that.
Yeah, it just depends on how well it does with the patients in clinical 1. If they see that it's promising, then they can speed up the process.
And you personally are very confident of it to be promising?
I feel very confident, guys. I read a lot of literature. I've been in this area 25 years. And again, Thermodox gave us a good benchmark, that company, right? We are improving with ultrasound, and we're also improving with targeting. So, and again, they did 5%. We need to do 25%, I feel confident that we can get somewhere with that.
So with that being said, and just to sum it up in a nutshell, what advantage does it have over the traditional cancer treatments?
So that's going to be delivered. It's a magic bullet. You're going to deliver it right to the tumor site without affecting the healthy cells in the body. So again, you're going to avoid the side effects. I think hair fall, cardiotoxicity, which is why it's toxic to the heart, problems with the GI tract, problems at the site of injection. All of these will be mitigated, maybe completely removed, because now you're specifically targeting the tumor.
Incredible.
And we're massive fans of AUS here on the Morning Majlis. I'd love to ask about the integration on this project when it comes to the students.
Yeah, so actually, if you look at the patent itself, there is, I'm on the patent. I'm a co-inventor on the patent. That's what they call it. I have Dr. Muhammad Sayyah. I'm a chemical engineer, so I'm from engineering. Dr. Muhammad Sayyah is from CAS, College of Arts and Sciences. And I actually have one of my master's students on the patent. Her name is Amal Sadiq, so 3. So pretty. She has 2.
Wow.
This young lady who's probably 27, 28, she has like 2 patents already from the lab. So that's pretty exciting. Yeah.
Very exciting times indeed, and wonderful to hear another success story emerging from American University of Sharjah. And it makes us very, very proud with this new cancer treatment. A targeted one in particular is getting the attention that it deserves, and we look forward to seeing some positive news emerging from those trials.
I hope next time we come in, we've already, we see good results, and maybe we're done with clinical 1, and then I can tell you what happened in clinical 1.
Exactly.
So.
It's an exciting time, that is for sure. Well, Dr. Ghaleb Hosseini, being the AUS professor in chemical and biological engineering, thank you so much for coming in and spending your morning with us.
Thank you very much.
If you'd like to catch that conversation again, you can do as a podcast. Just head online to SoundCloud, Spotify, and Apple Podcasts. But stay with us here on The Morning Mattress, because we've got so many more conversations coming your way.